Hi everyone, thank you for joining us. We're going to just have a couple of minutes where people join us virtually. Thank you to those people who are very promptly joining. I'm Emma Cox, Chief Executive of Endometriosis UK, and we're just going to wait for the first couple of minutes to let people join, if that's okay. This is a bit where if we were together, we'd be milling about and making sure we've still got our last bit of coffee and finding a seat. So thank you for joining us. As I say, big thank you to all of you. Lots of you very prompt. Thank you for that. We will be joined by Emma Hardy, one of our speakers soon. She's got business in the Houses of Parliament back to back with this. So she, I know her room is, I think it's 7 minutes run from the Houses of Parliament. So I think she's going to be joining us shortly. But as I say, we're just going to have a couple of minutes while people join. I'll just give it another minute and then I'll go through some wildly exciting housekeeping and we can take it from there. I'm delighted to be joined by Christian and Helen, who I'll be introducing properly later. And I was thinking back to Helen and I know Christian was there as well, went to our first ESHRE conference in Barcelona. Was it 3 years ago now? I can't remember now.
I think it was either 2017 or 18.
That was it. Yes, and it was really great to see all the work that was being done. So that was my first sort of international research conference for endometriosis. So welcome to everyone joining. I'm Emma Cox, Chief Executive of Endometriosis UK. We will have a couple of minutes while we let people join, but I'm going to just do a very brief bit of housekeeping before we start off. Well, thank you for everyone joining so promptly. We have a Q&A function. If you have questions, put them in there and we will answer as many as we can. For those of you where, depending on how many questions there are, we can't always get through them. There'll be a Q&A at the end and we'll be asking them of people. If we can't answer them all, we will take a record of them and see if we can get them answered afterwards. They will be anonymous though, so we'll put them out where we can. On that one, I'd be grateful if you could ensure that questions stuck to the topic and to no personal medical questions. I do know we have an excellent specialist surgeon with us today, but Christian can't answer any questions about personal medical situations. So please do keep your questions generic on that one. I'm just going to give it another couple of minutes, well, 1 minute, and then we will start off I think with things. Our first speaker, one of our speakers, Emma Hardy, who's an MP, as I said, is coming directly from a meeting in Parliament. So I know she has a little bit of a journey to do, so she'll be joining us as soon as she can. And I'm just we have got quite a few people now. So I think what I will do is I'll start off. I'm just going to talk a little bit briefly about what we're going to be doing today, what the agenda is, right. And then I will be introducing the panellists and we'll go forward from there. So thank you for joining us very much for this session, which is a virtual panel debate, as you know, a time for action on endometriosis. And I'm absolutely sure everyone on this call will agree it is time for action on endometriosis. We will be hearing from Emma Hardy, MP, Joint Chair of the Appg on endometriosis, Joint Chair with Hannah Bardell, on a view from Parliament and the work of the All-Party Parliamentary Group on endometriosis, which is doing some excellent work. We will be, I'll be talking through what we find Endometriosis UK are the most common challenges currently facing those with endometriosis. And then we have two excellent speakers. I'm delighted to see Helen McLaughlin, who'll be talking to us as a patient advocate who was involved in developing the ESHRE guidelines. If you don't know what those are, you will find out shortly. And we're delighted to have Dr. Christian Becker, who also chaired the development of the new European guidelines on endometriosis. And we'll be looking at those, having a Q&A. And if you're wondering why we're focusing on those, is because those is an excellent piece of work that pulls together the latest in endometriosis research and evidence. Christian will talk more about that. And it is a basis, it is likely to be the basis of any future developments of guidelines we have in this country. So I will, Emma is still on her way, I know, so I will kick off by just doing a short introduction to what we find are the most common challenges facing those with endometriosis. If Emma comes, I suppose there's two Emmas, Emma Cox and Emma Hardy. If Emma Hardy, or when she joins us, we'll shift over to Emma. So one of the things that I should introduce so I'm Emma Cox, Chief Executive at Endometriosis UK. And what we hear from the endometriosis community, and I'm sure many of you will have your own views on this and you can tell us in the Q&A, but at the moment we absolutely know that the backlog due to the pandemic is having a massive impact on the endometriosis community. The waiting lists are up everywhere. It's over 6 million, I think now. And that's for the whole of the UK, not just gynecology. But the biggest percentage increase in waiting times is in gynecology, which we are a little bit annoyed about, because I think we need to make sure that that those with gynecological conditions get the support and help they need. And there's a lot of work that we're doing. I know the Royal College of Obstetricians and Gynecologists doing an awful lot of work on that as well. We hear some very sad stories about people feeling forced to go private, some of them who can't afford it, can't do, or can go into debt over that. And also the lack of mental health support. People are finding difficult because of all the delays, the lack of access to support, etc. And so along with the lack of access is lack of access to pain management at the moment, by which we mean a holistic pain management process. And we know that that the lack of access and difficulties in getting care during the pandemic has been a real key driver for worsening mental health in the endometriosis community. I don't want to be all doom and gloom, but we do start by hear what we have. And I think, so what one of the campaigns that we will be launching tomorrow, in fact, I'll tell you about it today, is we are launching a campaign which the All-Party Parliamentary Group on Endometriosis are helping with or supporting. And so we would like the NICE guidelines on endometriosis reviewed. Now, NICE, National Institute for Clinical Health Excellence, set the care standards in the UK, in England, and that they sort of say, you know, they write guidelines, and that is what the NHS is supposed to do. And the first guideline on endometriosis came out in 2017, and it is a good baseline. It's much better. It took us forward. Good baseline for care. But there are gaps, and there's new knowledge since it was written in 2017. And so we're calling for that guideline to be updated, for that review to start this year, not just at some point in the future. And it takes a good 1.5 years, I think, to do like a full review and gap analysis. And some of those key gaps, a proper gap analysis needs to be done. But for us, we want to highlight 3 key gaps in the NICE guidelines. And that is that there is a lack of holistic an approach to pain management. There's a section called pharmacological pain management, and then one called non-pharmacological pain management, so drugs or not drugs. And unfortunately, there is nothing in the non-pharmacological one. When it says something like Chinese herbs don't work, but we feel that could be more constructive. And so we'd like to see a lot more in there on pain management, and so that people with endometriosis or suspected endometriosis can access pain management when they need it in a way that works for them holistically. And Helen and I quite often talk about pelvic physios. I think Helen, I know, has benefited from, and there's all things like that we think, well, why isn't this just in here? So we want some improvement in pain management. We want mental health to be included because it isn't at the moment. And we want endometriosis to be considered holistically. And we also would very much want to see endometriosis outside the pelvic cavity included. So whilst endometriosis is generally considered a gynecological condition, we know that for up to 12% of those with the disease, they might have endometriosis outside the pelvic cavity. And so sort of diaphragm and above is how I think of it in very basic terms. You know, at the moment the NICE guideline on endometriosis is purely for pelvic cavity endometriosis, so we want that to be updated. So we will be pushing for that to be changed. We'll be sending a lot of stuff out in our social media in the next couple of days, asking you to write to your MPs and get them to sign an early day motion in Parliament to say that they want that updated. Now, I can rabbit on endlessly about endometriosis, but I should stop at that point. And Helen, I'm going to hand over to you, if that's okay. Now, Helen McLaughlin has personal experience with endometriosis, and a big thank you, Helen, for all the support and work you do for us. Helen is leader of our London support group since 2015, and so as well as her own experience, here's an awful lot of personal accounts and challenges of those living with the disease. Helen was a patient advocate on the 2 working groups on the ESHRE guideline development, and also has professionally is an accountant. So make sure that we're on the straight and narrow. So Helen, you're going to talk to us about your perspective of the endometriosis community and patient involvement in the guidelines.
Perfect. Thank you, Emma. So thank you for inviting me to speak. I am here today to share my story, and I was diagnosed with endometriosis in 2011 after experiencing my first symptoms 10 years earlier in 2001. I was simply told to go on the pill. By 2010, my symptoms rapidly increased, and over an 18-month period, I reached a point where I was unable to work, I could barely walk, and I was on 25 tablets a day. Despite all of these tablets, I was burning myself with a hot water bottle for pain relief, and my mental health was severely impacted. Endometriosis took over every single aspect of my life. Since my diagnosis, where I was simply told, good luck, I've gone on to have 4 more surgeries, a temporary medically induced menopause, more drugs, more hormones, more have you tried, and even more aren't you better yet. I've lost relationships, jobs, and my sense of self. For me, endometriosis has led to over £80,000 of unearned earnings, let alone the daily expense of having a chronic illness. So even if I was cured today, this condition has impacted my financial security forever. Living with a chronic illness is an expensive burden, not just for me, but for employers and the UK government. During my diagnosis years, a chap on TV declared, and I'd love for us all to take this with us today, that the most constant thing in the universe is change. And let me explain why I'm quoting him today. As time progresses, so do we. There are things that were said 10 years ago which aren't acceptable today, and things we'll say that today that in 10 years' time won't be appropriate. The same goes for endometriosis. With endometriosis, progress is hard to measure, especially when the thing, the endo, is invisible itself. And so let me share with you some of my stats to show you signs of progress and change. When I first started volunteering in 2015, the London group had 500 members, and today it has over 2,300 members. The London Worldwide Awareness March started with 20 people on a Thursday in 2014, and in 2020, just before COVID, we had over 800 people registered. The role of the clinical nurse specialist is widely recognised as being worth their weight in gold, and in the past few years, the BSG and the Royal College of Nurses have increased the level of support and training required, and a number of hospitals are now engaged in the services of pelvic floor physiotherapists. As discussed earlier, the ESHRE guidelines were published in 2014, and their revision was published in January 22. The NICE guidelines were published in 2017, and I'll loop back to those shortly. We've had MPs speaking openly about their experiences of endometriosis, with Paula Sharif kicking open the door with the tampon tax debate. And all of this has happened in the 10 years since I was first diagnosed. However, as too many of us know, it's not all positive. I'm heartbroken to know that the average diagnosis time has gone from 7.5 years to 8 years. COVID has had a devastating impact on waiting list times, with some women waiting more than 2 years just for a consultant appointment. This constant hamster wheel of waiting for appointments, waiting for treatment, and waiting for surgery is leaving a lot of women and people in a desperate place, vulnerable to financial and emotional exploitation. There is also the gender bias at the very grassroots of our care, with the allocation of funding to support research. I'm placing huge hope and responsibility with the MPs who voted to increase funding into this area. Now, endometriosis affects us all differently, and no 2 people are impacted the same. But the one common theme we have is the reliance on guidelines to form standard pathways for our care. This belief is what led me to work on the revision of the ESHRE guidelines. We deserve to be treated with the most current and up-to-date understanding of our condition. Not only this, but it gave so many opportunities to learn for myself and the professionals involved. It was definitely a 2-way street. One of my proudest moments of the guidelines was standing my ground and requesting that a particular wording was changed from focusing on our breeding ability to focus on us as women and people who deserve a pain-free life. Now, to ensure constant change, we must constantly review. And that is why I'm here today, echoing and supporting the calls from Endometriosis UK for the MP support for the revision of the NICE guidelines on endometriosis. Guidelines have the scope and breadth to capture us all, and at the moment, these current NICE guidelines fall short. I know that the evidence is out there to change them. We deserve this at the very least. And finally, with events such as this even more accessible online, as we're here today, afterwards, quite often we get posts in our Endometriosis UK support groups with people feeling very heard, but also very frustrated. And I just want to finish by speaking directly to people watching at home, those of you with hot water bottles, those of us wearing elasticated waistbands, and those counting down the minutes until our next dose of painkillers. You are the reason we are here today. I want to remind everyone who is currently feeling small, unable to hold on, or unable to see the light at the end of the tunnel, like I have done in the past. You are never, ever too small to make a difference. To use another quote, if you feel too small to make a difference, try sleeping with a mosquito in your bedroom. Please keep your hope, knowing that so many people who are listening to this are fighting to make things better for us. Better days are coming. We'll make sure of that. Thank you.
Thank you, Helen. And I look forward to continuing to campaign with you to make changes. Thank you so much at all, very much. Now I'm going to, so Emma Hardy, who's due to be with us, there is a vote in the Houses of Commons, so she has been held there. That's her job, she has to vote. So I'm going to move on to Christian, Dr. Christian Becker. So Christian is I better get this one right, a professor, I should say, Professor Christian Becker, who's consultant gynecologist at the John Radcliffe in Oxford, as well as an associate professor and co-director at the Endometriosis Care Centre at Oxford University. He chaired, as you know, as I mentioned earlier, the ESHRE Guideline Development Group, so developing guidelines on endometriosis for the whole of Europe. And he's going to be talking to us about those guidelines now. Christian, can I hand over to you, please?
Thanks, Emma, and thanks, Helen. So I think for all of those who think that Helen's story is unique, it is not. It's very, very common, unfortunately. I think we definitely need to change something. I prepared a few slides, so I'm going to share my screen. Just give me a quick second. So here we go, and I hope you can see this now. Is that all right? I'll make this a bit smaller here. I was asked to talk about the new European guideline or guidelines on endometriosis, and they're under the umbrella of ESHRE, which is the European Society for Human Reproduction and Embryology. Just briefly, oops, here we go. My conflict of interest, I don't know if you can see this or it's just me here, all right. I have done some consultancy. We have received various research grants in Oxford, but I haven't profited personally. I haven't received any money for this. It all goes into research in the university. So the ESHRE guidelines originated in 2005, actually. So those were the first guidelines ever that I'm aware of for endometriosis for certain, but also from ESHRE. And ESHRE is a society that was founded many, many years ago by people who were interested more in reproduction mostly. Bob Edwards, for example, was an early member of ESHRE. And I assume ESHRE took this on as the endometriosis guideline because, as we know, about 30 to 50% of women with endometriosis have fertility issues, and that's how all of this came about. So in 2005, there was a group of, I would assume, probably 10 people, experts in the field. I think they were mostly, if not exclusively, doctors, and that again has changed, fortunately, since then, where they looked at the evidence with the tools that were available at the time, and then came up with suggestions of how to best manage endometriosis. Now then, at ESHRE there is also a process existing to update these guidelines. So the second guideline updated in 2013 and published then in 2014. Where I was involved in that, and we were already involving patient representatives at the time.
We'll take that.
Pardon? Oh, sorry. And since then, we updated it, and this was just very recently published on the ESHRE website. You can all look this up. This is freely available to anyone, and I'll show you a little bit more about this in a minute. So this is the most recent guideline using the most recent available evidence on endometriosis. So the way this is done is obviously there's a topic selection, and then the guideline development group is formed. When I became chair, I decided to actually dissolve the old group to ensure that we're not seen as a little club that just every few years meets and talks about things, has a jolly, and then come up with some form of guideline. So we dissolved the whole thing, and people had to reapply to become members. And what I wanted to do was to be a bit more inclusive. So again, it's not only a group of 10 people there. So the problem with that, though, is if you are trying to chair this, if you have 40, 50 people around the table, it will not become a guideline. And what we therefore did was we had about, I think, 13 chapters that we had to deal with. And each chapter had a lead who then came together in the core group. But each chapter with the lead had it varied between the different chapters, between 3 and I think 6 or 7 colleagues, that were not in the core group, who helped assessing the evidence and drafting the recommendations for that particular question. So the evidence was searched and then synthesized by a professional data person from ESHRE. And as I said, then as you can see here on the 7, the recommendations were drafted. We came together then as the core group and formed the draft recommendation. This then went out to the stakeholders. Every ESHRE member was able to comment on this, and then we took on board those comments into the final draft, which then excuse me, went to the executive committee of ESHRE. They approved it, and it has been publicized now, and a paper is coming out from this as well. And then in another 2 or 3 years, we would need to update this, look at minor changes, and if we find things have significantly changed, we would have to come up with the entire new guideline. So those are the chapters that we looked at. I think there were 13 chapters and sub-chapters that we involved at this time. And these are the guideline core members. As I said, those were the leads for the different sub-themes. As you can see, a lot of medical doctors, but also patient representatives, epidemiologists, and information specialists as well. So a good mix. We came up, and that's not only us, also people from the outside, we came up with 35 so-called Pico questions. So those are questions that look at patients, interventions, comparisons, and outcomes. So those are criteria that are generally now used for guideline development. For the NICE guidelines was the same thing. And then also we had 7 narrative questions, just because you couldn't fit them into this umbrella of Pico questions. We came up with 109 recommendations and good clinical practice points. These good clinical practice points came about when there was no proper good evidence available, but where we as a panel thought we need to, we cannot entirely answer this question, but as people with some experience with endometriosis, we thought this would be something to consider. But what we also found was that there was a hole in our knowledge, and therefore we also came up with 30 research recommendations. So what are the changes since the last guideline in 2014? And the first one is probably the one that is most contentious. I'm sure there's going to be some questions about this. that, you know, we always said that laparoscopy, and this was actually formulated in the first guideline in 2005, that laparoscopy is the gold standard for endometriosis. And there's some data now to suggest that that's probably not necessary for all endometriosis cases. So, for example, ovarian endometriosis can quite reliably be seen and ruled out with good ultrasound scan. And for deep endometriosis, probably the same is true, with a caveat that you probably need someone who's experienced doing this. And again, I'm very happy to discuss this in a minute. Treatment of endometriosis is the associated pain. So GnRH antagonists are, drugs like, Zoladex that we use widely here, or others here in the UK or abroad, which are usually monthly or 3-month injections. Antagonists are, slightly similar approach in an oral form, and they are coming on the market in the US, but also in Europe, and maybe at some point in the UK as well. There is some data to indicate that if we do surgery, that we probably should consider some hormone treatment afterwards as well, to reduce the risk of recurrence as well. If you think about fertility, endometriosis-associated fertility, one big change was, this is quite specific, those women who were undergoing IVF after surgery for severe endometriosis or stage 4 endometriosis. In the old guidelines, we said, well, it would be best to downregulate the ovaries, to shut them down for about 3 to 6 months, because there were data to suggest that this improves then IVF success rates. Newer studies have not confirmed this, so we're stepping away from that. And then one new thing that I think is important for also patients, that you really should ask your doctors if you're having surgery for fertility reasons, to ask them about the endometriosis fertility index. This is probably the best staging system, if you wish, to assess your chances of being able to conceive naturally after endometriosis surgery. So that takes into account various things: the way endometriosis presents itself during the operation, what the ovaries look like, the fallopian tubes, how old the patient is, whether she's been pregnant before, etc. And this all then gives us an idea of, what is your likely percentage of conceiving in the next 12 months, 24 months, etc. So that's really something that I think should be implemented widely. We also took on board endometriosis and adolescence this time, which we hadn't really dealt with before, and also in menopause. Not that there's a lot of evidence about this, but we really thought it needed representation. And as well, there's an update on endometriosis and the association with cancer. So just my final slide. I think what is very important is that there is a very large guideline, as you can see on the left-hand side on the ESHRE website. On the same website, you can also find a patient-friendly version, so something that is really understandable. We try to write it that way that people without a medical knowledge or depth of knowledge understand it. It is also, or it will be translated into Dutch as well, and possibly in other languages as well in the future. So I think I end with this, and I'll stop sharing and give back to Emma.
Thank you, Christian. Delighted to see that, and it's really interesting to see some of the new developments coming forward in that. Now, I've got an update on our other presenter, Emma Hardy. Emma is, as I say, a working MP and is at work at the moment. As for those of you who know how the Parliament work, is if there's a vote, the MPs actually have to be there physically to do that, and there's a vote taking place. So she will join us if she can. I know she really did want to be here, so we'll see how things go. Oh, Emma's in, just arrived. Emma, if you're listening, I'm supposed to do an admin on this, is you should have a personalized speaker email, which I'm sure Rebecca will send you, sorry, a link. So I think you've gone into the generic group. So we totally understand that you've had some votes, and Rebecca will be in touch to get you linked in to be a presenter. So just have a look out for that. Well, as soon as that's done, Emma, we'll ask you to speak. In the meantime, to start off on some questions, if that's all right. Christian, you touched on the scanning thing and laparoscopy not being gold standard, and someone's been asking about, you know, we have a smear test every 3 years, can't we have a scan regularly to see how endometriosis, if there's endometriosis? Now, I quite often have this discussion, as you know, and some endometriosis shows up on scans, but not all of it. To be honest, and also it depends on the quality of the person doing the scan and the kit. Do you just want to say a little bit more about why scanning can show up some endometriosis, but it doesn't show up all endometriosis? You're on mute, by the way.
Sorry, beginner mistake. At the moment, as some of you or many of you know, we subdivide endometriosis in superficial or peritoneal endometriosis, into ovarian endometriosis, which means ovarian endometriosis cyst usually, and then also into deep endometriosis, or, you know, we used to say deep infiltrating. There's some discussion about whether this really infiltrating or not, but let's say deep endometriosis. Ovarian endometriosis, meaning ovarian cysts, you can see, you know, quite reliably, actually, with even not very educated ultrasound scans nowadays, because unless they are entire, you know, very, very small, I think anyone who has ever done ultrasound scan can see a cyst on the ovary. For deep endometriosis, it is really probably reliant on the experience that the sonographer or the radiologist or gynecologist has, and that is something that probably needs to be implemented more widely in the UK, but also worldwide, to really say, you know, I have had an educated ultrasound scan, and not just one that, you know, very quickly tells me there's a uterus there, looks at the uterine lining, and, you know, the ovaries are there or not. And that, you know, we see this very, you know, often still, unfortunately. You know, to your question, Emma, about can't we just have an ultrasound scan every 3 years? Well, you know, as you hear, I'm originally from Germany, and, you know, it's a different health system there, where, you know, patients see their gynecologists every year, normally for smear tests, you know, as opposed to every 3 years over here. And usually the gynecologists do an ultrasound scan. Now, it has its good and its bad sides as well, because sometimes you see things that, you know, then evoke further investigations that are not absolutely necessary. So there's pros and cons to that. However, I think if you have symptoms, then I think you should have access to that. And I think the GPs should have a relatively low threshold to organize imaging, definitely.
Thank you, Christian. Now we'll come back to questions in a bit, but we do have Emma with us now, Emma Hardy. Emma, thank you so much. I know you've probably had literally a run from the house to get to your room. I know exactly how far it is, having seen you do that. Emma Hardy is joint chair of the Appg on endometriosis, along with Hannah Bardell, and delighted as I am that Emma and Hannah are chairs. Obviously that was due to the sad and untimely death of Sir David Amos. And I always remember when I'm doing Zoom calls, because Sir David told me off once for having a very boring background. Christian, he wouldn't have liked yours. And so I literally moved my office around so I had a better background for Sir David. Anyway, Emma, you're going to talk to us a little bit about what the Appg is doing at the moment. Can I hand over to you, please?
Yeah, thanks everyone. Apologies for being so late. It's the Nationality and Borders Bill, so we've just had 8 votes, and we've got 6 more coming up later, and I'll let you all Google that and find out exactly what's been going on and what we've been voting on. So apologies, I couldn't be there. And as I think Emma's explained, Parliament is, shall we say, traditional, and so hybrid voting lasted a short while in the pandemic before it was deemed that we had to all be there in person to be able to vote. So the All Party Parliamentary Group is one of the most active, in my opinion, one of the most active APPGs in Parliament, and it's usually, you know, very well attended, and it's an issue that I found as I speak to more and more parliamentarians, they're having people go to them and talking about endometriosis. So thank you to everybody listening who has gone to their MP and lobbied them it's great, it works, and it means that they come to our all-party parliamentary group and that we make things happen. In the nearly 5 years since I was first elected, the issue of endometriosis has been spoken about so much more in Parliament, and our report that we did when Sir David was chair was, I think, quite a sea change in the way that we look at endometriosis and the way that we approach it. And we want to continue that. We made the promise that it wouldn't be a report that would be left to gather dust, and that's something that we're keen to see actually happen. So since then, there's been some interesting debates, one looking at research, and we've all probably maybe similar opinions and reasons why there doesn't seem to be as much research into issues like endometriosis compared to other health conditions, but I won't get on that soapbox now. But it was good that we had a debate about it and that we've raised it as an issue. We're going to continue to sort of look at that issue around research, but the biggest problem is around diagnosis time, the number of times, of course, that women are having to go back to the GP and go back to health professionals before they're diagnosed. And I think we'd be naive if we didn't think that COVID is going to have an impact on this. We've already seen waiting times increasing for all other conditions, and so there are huge concerns that endometriosis is going to suffer more in terms of diagnosis and more in terms of treatment. But I'm always try and give some hope, and some of the hope is around some of the other research work that's been going on, looking at endomarkers and looking at sort of how we can identify endometriosis more quickly. So there is a reason still to be cheerful. So we want to sort of continue to keep endometriosis on the agenda. One of the other things we're sort of pushing is around the revolutionary change in the way we work and hybrid, and the fact that we're all now chatting away on a Zoom meeting, and this is considered normal. And even though 2 years ago, if you said, oh, let's have a Zoom meeting, people would be wondering what on earth you were talking about. And now we're doing it now, and we're talking to everyone, which is brilliant. And so what we want to look at is making employers, sorry about the noise, just to explain the geography, my office oversits Parliament Square, and I have the window open because obviously in Parliament there's no such thing as sort of air conditioning or anything, so it is the window open. And because of being in Parliament Square, you'll hear all the sirens and usually protests, so apologies about that. So what I was saying about the endometriosis friendly employers is another thing that we really want to push, and looking at endometriosis in the workplace and how women are treated when they have endometriosis, and the concerns around it triggering sort of disciplinary processes if you have too much sick time, if you have too much time off, and what we can do about that. So that's one of the things that we'd like to have a debate on soon, and show that because we can work in a hybrid way, because there are flexible ways of working, to make sure all those options are open to women who have endometriosis, and it not being seen as as we heard in the evidence, that women aren't getting the promotions, they're losing their jobs because of them having this, the health conditions. That's something else that we're quite keen to pursue. Now, because I dashed over from the voting chamber here, I left my notes, not that any of you can tell, on covering all the points that I was going to make. So I'm hoping that Emma Cox can pick up on some of the other ones we've missed. But really, what I want to do is keep this on the government's agenda, ensure that that after COVID and all the impact that's had on the health conditions in general, that this doesn't end up at the bottom of the pile, that it is still seen as a priority to reduce those diagnosis times, to look at making employers more endometriosis friendly, and push the way that we've changed in work to employers so that they're looking at a more flexible work practice and how that can aid women who have endometriosis as well. And I'm hoping Emma's going to pick up the points that I've missed, but thanks everybody for joining today, and please do keep nagging your members of Parliament to attend our meetings. Thank you.
Thank you, Emma. Very well done without notes. Well impressed. So, one of the things we did touch on the COVID delays, and I think that one of the things and one of the questions we've had is that, really sad story. Jen, was waiting for surgery. She'd had her pre-op and her prep. She got cancelled. It was then too late because she'd had to do prep, and then she had to pre-op again, and then she, and this like horrific cycle of not getting the appointment you need. And I think, Emma, is that the sort of thing that if you've got a constituent who's having real problems getting surgery, is that something that an MP can help with, do you think, to contact your MP?
Yeah, I think it's always worth trying. It's something I've done for lots of people living in my area, and it you know, to get them to advocate. I mean, MPs, part of MPs' role is to advocate on behalf of their constituents, and you know, it's that thing, is it? And I'm going to sound like a school teacher. If you don't try, you're always going to fail, aren't you? So it's worth trying. And so if you can make the case and sort of argue it, then it's definitely worth trying. And I know that I've done that. I mean, I'm very lucky in that we have the incredible Mr. Phillips, who's runs the Endometriosis Centre, which is not in my constituency but just outside, and he is pretty amazing. And but of course I realise that the situation is different around the country. But I would say, if you are waiting, you do keep getting turned down, there's no harm in asking your MP to advocate on your behalf, because it is, you know, one of the reasons they're there.
Thank you, Emma. I'm going to stick with another question for Emma, actually, if that's okay at the moment. So before I do that, Emma, I was saying I was saying earlier that about the EDM that you've just recently tabled with Hannah Bardell, and so although we haven't officially launched that campaign, we've just been letting people know here. So big thank you for doing that. And I think if we can get the NICE guidelines reviewed and updated, it will be another step towards improving care in this country. It's quite interesting, actually, because in Scotland, in the Scottish Parliament, they're actually doing an awful lot around endometriosis. So they've made a commitment to drive down diagnosis times to a year or less, and to invest more in endometriosis. And it's going to be interesting to see what the women's health plan that the English government is doing will bring in on that. So thank you, Emma, for tabling the EDM on that. We'll look forward to promoting that. Someone's just asked that, Emma, you touched on employment and is saying what support and employment support can we expect from sufferers of endometriosis? It isn't listed as a disability, and there are few endometriosis-friendly employers. What options can be expected? And feeling that the debate on Parliament didn't get us anywhere. Now, I'll ask Emma to comment on that. I'm just going to comment on the disability thing. So the way that disability is defined in the UK is that anybody that is disabled by a condition is recognised as having a disability. Very, very few conditions. I think there's like 3 or 4 conditions. 3 conditions. And the reason is that for something like endometriosis, there are many people disabled with it, and they should be recognised as having disability, but there are others who are not disabled. It's a spectrum condition, and some people are not actually disabled by it. But it is definitely, employment is that area that we certainly hear an awful lot about, people having real challenges, and it impacts especially, say, early career people who can't really, you know, influence what happens, for people who are in retail or jobs where they're standing up a lot, etc. So that's why we started the Endo Friendly Employer Scheme. We know that it hasn't got many, but we are expanding it. But I don't know, Emma, if there's anything else you'd like to say. I know that, you know, the debate in Parliament, things don't always move quickly in Parliament, but they do move things forward, don't they?
Yeah, I mean, when you have a Westminster Hall debate, you're not going to result in legislative changes. I mean, to have legislative changes, of course, you need an act of Parliament and the amendments, and you know, this is what's happening just now while I was late, the Nationality and Borders Bill. But what the debate in Parliament does is to try and raise awareness and talk about best practice and set that. So it's a start, but it's obviously not the end. I mean, the end would be wonderful if the government decided to look at sort of employment practices and fire and rehire, and they've been promising an employment bill for a very long time. Wouldn't it be wonderful if one of the clauses in that bill related to how do you treat people with health conditions like endometriosis, and the policies that relate to that? That would be where you'd get law change, legislative change. But in the meantime, in terms of what we can do, obviously trade unions, if you have them, they can be there talking to businesses, to HR departments. Again, as a local member of Parliament, that's something I've done. Sometimes women want me to, sometimes they don't, so I have to be sensitive to what people prefer and how much they want me to wade in. So what I'm doing instead is I'm talking to the trade unions, and we're looking at writing a joint letter to some of the businesses where there's trade union recognition, to ask those businesses to adopt the model set out by Endometriosis UK around how do you become an endometriosis friendly employer. So we're talking to sort of all of the big ones, as you might expect, where you have those recognition agreements. The difficulties tend to be, in my experiences, where you have smaller SMEs and you don't have that HR department that are used to sort of looking at these bigger issues, and you don't have those recognition agreements in place, and that's where I suppose it can get a little bit more tricky again as to how much do you want to involve your member of parliament in talking to these businesses and negotiating with them. But what I'd really like to see is if you can get the bigger companies adopting it, then you can start to get the smaller ones. And there's a really good example, a good model to follow, which is, I don't know if you've all seen or heard of the GMB campaign, Dying to Work. This was a campaign which was started by the GMB, adopted by the TUC and various other organisations. It was called Dying to Work. And what this basically said was, if an employee is diagnosed with a terminal illness, then they won't face disciplinary action related to poor attendance, and they won't be sacked. Because they're unable to do their job, and what this means is they're then entitled to death in service benefits and various things if you're still registered as an employee at an organisation. There is a really awful that even that happens, but it does. People are sacked when they have terminal conditions because they're seen to be not fulfilling their contract and being unable to work. So that was a really successful campaign. It started off by getting all of the big organisations to sign it, and then that's filtered down to some of the smaller ones, and that work's ongoing. And I think we can do something similar with being endometriosis friendly. Get the big businesses to sign up, get those businesses to start promoting it on their social media so they can start talking about it, and then we push for some of the other ones. But if you work for a small SME and you're struggling, and you don't have trade union recognition, and there isn't sort of a formalised HR department, then I'd recommend talking to your individual member of parliament. But I think it's something that we really do need to pursue, because I think in some cases it's that businesses genuinely don't understand, and I think in other cases it's that, how can we put it, they're not sensitive enough to the needs. And I think whatever the reason is, we need to try and ensure that that women with endometriosis are not penalised against because of their health condition.
Thank you, Emma, for that. And I'm going to ask a question initially to Christian, but Helen, I'd be interested to hear if you hear more of this. So someone's asking about extrapelvic endometriosis, Christian, becoming increasingly recognised, and sort of they're wondering what is being done for people who present with those symptoms. With, you know, how does it get diagnosed, that sort of thing. So I know that there's no direct answer to this, but could you just say a few sentences about that, please?
That's right. So to be fair, we're struggling with that. I mean, probably the most common extrapelvic site of endometriosis is in cesarean section scars, I would think, and then on the diaphragm as well. Now, cesarean section scar is, you know, accessible, and you can probably see this with ultrasound or MRI. If it's on the diaphragm or in the lungs, if you're lucky, you can do it with an MRI. You know, as we all know, those lesions can be quite small, and you may miss it still. So if it's negative, it doesn't entirely rule it out. Clinically, what we often do is we treat, again, empirically, similar to general endometriosis, with hormone medication for the better or the worse. And if it gets better, then again, it suggests maybe endometriosis.
That's great. And Helen, have you been noticing any people coming through to support groups with extrapelvic?
Yeah, definitely. There's definitely been people are more aware of it, I think, so they're a bit more suspicious of if it's but what we tend to tell people is to keep a pain and symptom diary, regardless of where your pain or symptoms are, and you can use that to rationalise yourself, so that when you go to a doctor's appointment and you're told this isn't real, or, you know, it could be this, you're able to see the pattern, so it just rationalises what you're thinking. And then also, yeah, it's useful to hand over to a medical professional or to let them read through, just to see what your symptoms actually are, because in the heat of the moment, when you're waiting such a long time to see someone, people just forget what they're wanting to ask, and what they've gone in there for, really. So yeah, pain and symptom diary is what we recommend.
And I think there's a movement by the BSGE to try to create you know, a few centers that specialize on that. So for diaphragmatic endometriosis, if they need surgery, because that's definitely more complex than what a normal gynecologist would deal with, because you usually need a thoracic surgeon as well. So that should be probably done in not only the BSG centers, but probably only a few of them who specialize in that.
Yeah, and the BSG and the RCOG did issue a statement not long ago about this, and actually we're going to be doing an Insta Live with them in a couple of weeks about what their views are on that. So we'll more about that, but it is one of those areas. And the question also was said about how do we get it recognised with GPs. And I think, as we talked about, one of the things we're keen to see in the review of the NICE guidelines is to include extra pelvic endometriosis, and that starts on the process of getting it into education and other things as well. So so there's some work to do on that, definitely going forward. Quick question, Christian, you mentioned ultrasound, but then when you were just in your last session, you talked about last answer, you mentioned about MRI might show up something. How effective question is, how effective are MRI scans at detecting endometriosis?
So for ovarian and deep endometriosis, I think the specificity is about, if I remember, about 85 to 90%, roughly like that. For ovarian, I think it's higher than that. For deep, it's slightly lower. For peritoneal disease, it's low. I don't remember the numbers, but it is not high enough where we would say, if someone has a negative MRI, that we can entirely rule out the disease. And coming back to the question, and I saw there was some chat about this as well, laparoscopy versus no laparoscopy. So I think for those women who who've had medical treatment and it didn't work, or it was inappropriate, or also for those who who've been suffering for a long time and really want to know, I think laparoscopy is still absolutely a way of showing and diagnosing endometriosis. I just think that if you have suspected endometriosis on MRI or ultrasound scan, you don't necessarily need a laparoscopy. I mean, it may be part of your treatment plan, that's fine, but to diagnose it, it's not absolutely necessary. And that may then help as well to reduce waiting times possibly as well. If you have a diagnosis and your patient is happy to be treated non-surgically, maybe that slot can be used then for other things.
Great, thank you, Christian. We've got time for a couple more questions, and then I'm going to hand back to Emma Hardy to close the event. So one of the questions we've had from Angela, who's asked, apart from the long time to diagnosis, is there any data on how long it takes to receive treatment after diagnosis, etc.? One of the issues we have, Angela, at the moment is there's some data from before COVID, but as all the surgeries and appointments got basically cancelled due to COVID, and they're starting up again, but not everywhere. There's some real variations at the moment. There's not really much solid data because each actual centre and hospital is having a different time. So pre-COVID, it varied across the UK, but most people would have got treated certainly within a few months to a year. But again, there's some challenges at the moment, and I do know that the Royal College of Obstetricians and Gynecologists, the RCOG, doing an awful lot of work on this and about trying to find the evidence of what's happening at the moment so that the changes can be improved on that. Oh, where's my question? Sorry, just whizzing through here. So we have very specific questions, which is for Emma, actually. So are civilians allowed to attend APPG meetings?
Well, yes, but obviously during COVID, people couldn't attend because there was really strict rules on who's coming in and out. So it's always worth checking what the latest rules are in terms of attending Parliament, just so you don't set off and then find out that actually people aren't allowed to attend and they've restricted access to them. And if you want to attend, if you're able to sort of let either me know or sort of let Emma Cox know, just because I know it sounds really dull, but it's the size of the room, because there's lots of different rooms and we have to book a room for everybody to meet. So obviously if we know some people are coming, we'll book a bigger room. So it's, if you're able to do that. What we've tried to do though is to put some of the meetings on Zoom, similar to this, on Zoom or on Teams, and then people don't have to worry about physically getting to London, because I know certainly I represent Hull, and the idea of people travelling from Hull to London can be really difficult. So we're trying to look at sort of putting some on, and Emma and I were discussing this with Hannah about how can we sort of involve more members of the public in them, and I think virtual is probably the best way to sort of go when we want to do that, because of the, and then there's the accessibility. I mean, it depends, there's all these other things. So yes, but I suppose is the rather dull answer. If you wanted to attend, if you were able to let us know, then we can make sure we've got the right room. And if you have any health needs and conditions in terms of accessibility, then it depends whether therefore we put the meeting in the Palace of Westminster, or whether we try and put it somewhere else, because in the Palace of Westminster, of course, there are no lifts. So, we need to look at accessibility needs as well. But what we would like to try and do is to plan some more events like this, so that people can join just by a link, and we don't have to worry about physically getting people down to London. When there is a debate, you are definitely able to come, and there is even space for you to sit and watch. So that's always I think quite interesting. So if we have a debate in Westminster Hall, there's a space actually in the room where you can come and you can sit and watch. If we have a debate in the main chamber, then there's a space up at the top you can stand in, you can sit in and sort of overlook all the proceedings. So when there's a debate, you're able able to come and sort of watch all of those. But I think, Emma, have we published when our next meetings are for the APPG and what exactly we're doing?
I'm not sure if they're out yet, actually. I think that just to recognise that Emma and Hannah have stepped in as chairs, and we're delighted about that. But obviously, things did get a little bit disrupted with the sad demise of Sir David. So a lot of things had to be changed and things like that. So we will be getting those out once we can get dates. And as Emma says, one of the things about doing more things virtually is like lots of people can come along and chat, rather than it being a few people who happen to be able to do that. I'm going to ask Christian if you can do one very brief answer, and then we're going to hand over to close off. So somebody's asked about and you touched on it in your talk, but what about infertility with endometriosis in NICE guidelines? Is that something that we need to look at?
Yeah, so infertility, so patients who are infertile, there's two things. One, patients coming through the door knowing they have endometriosis, and then Dr. Google says, I'm not having any children, and you hear that quite often. So I always tell the patient, if you're ready to, or when you're ready to have children, give it a try. I think it's not appropriate for doctors to say, have endometriosis. If you have endometriosis, have your children now. I don't think that's a good approach, really. And you hear this time and time again, unfortunately. If you have infertility, as proven infertility, it's difficult to conceive, and you have endometriosis, then usually there are two options. Either a laparoscopy is done and try to improve, so first of all, investigate whether the fallopian tubes are open and try to improve the anatomical situation, which is probably one of the reasons why it may be difficult to conceive naturally, or consider IVF as an option, or IUI as well.
That's great. Thank you. I'm just going to touch on one question myself, if that's okay. Somebody's asked about the focus on management of mental health, and whether there's any sort of implication that it's therefore not a physical disease, or it gets contributed. Just to flag that we recognise that mental health impact of the long diagnosis, and also for people who aren't able to get the treatment they want, or where the treatments don't work. So I think what we're not saying that in any way detracts from the physical impact of endometriosis. It's just looking holistically at the individual and providing support where it's needed. I'm afraid we've run out. We've got some great questions we've not yet answered, so we'll try and get to answers later on those, and see what we can do about promoting those. But Emma, could I just hand over to you to close the event, please?
Oh, thank you so much, and apologies again for missing the first half of this, and thank you to Christian, thank you to Helen, and of course to Emma from Endometriosis for being here. Please do keep in contact with the group. Please keep in contact with your Member of Parliament. I sincerely mean it. If you lobby your MP to attend an event, they usually will. because I know I get lobbied to attend events, and I usually do wherever I can, because we need more members of Parliament speaking out about this and making some noise. We are promised, as mentioned, an employment bill by the government. This feels like a real opportunity to talk about endometriosis-friendly employers and actually turn it from just a conversation and awareness raising in Parliament to something that actually means that we have that legislative change needed. But we will continue to talk about this. This is a huge issue, and definitely look at making our as many APPG meetings as possible virtual. But as Emma explained, of course, we didn't expect to take over as chairs. We're delighted to be chairs, but we wasn't expected. And so if you just bear with us while we just sort of get all these things in motion, that would be really appreciated. But thank you very much for attending this evening. Thanks again, Christy, Helen, and special thanks to Emma, who does an incredible amount of work at Endometriosis UK and is often that person in the background doing all the hard graft who goes unnoticed. So we've noticed you and we think you're doing a wonderful job. So thank you and good night everyone, and have a lovely evening.